The genus Shigella is another gram-negative rod that's an enteric. This one is non-motile, doesn't form an endospore. Urease negative, hydrogen sulfide negative. This one, though, is a parasite. It's a parasite of humans, and it has been shown to be able to infect some apes. The different species of Shigella can cause, roughly the same disease, but that disease will vary in intensity depending upon which species. From a clinician standpoint, an ID lab standpoint, since it is just it's a gram-negative rod, that when they do the gram stain and they look at, fecal sample or whatever, they need to make sure, you as the clinician, or if you're going to be in the ID lab, you need to make sure that you differentiate it from E. coli. Okay? Differentiate it from E. coli, which is another enteric, because Shigella will not respond to the same antibiotics as E. coli, and depending upon which species you have of Shigella, it can be deadlier than E. coli. With Shigella, you're going to get what is referred to as frequent watery stools. Okay, this is where you're going to be losing such copious amounts of diarrhea. It's going to be passing out of you that it can actually lose color. You've passed out any materials that were in the lumen of your large intestine. Now you're passing out, might be slightly tinted fluid. Intense abdominal pain, nausea, vomiting. And for some patients that have shigellosis, remember, shigellosis is going to be infection with the genus Shigella, you can end up with dysentery. Think the watery stools, but now that watery stool is going to be tinted, if not flat out red, from all the diarrhea you're passing out. Okay? As we're going to see in a later slide here in this lecture, Shigella produces what is called the Shiga toxin. And that has some very, very bad effects to the epithelial lining of our large intestine. You will literally be sloughing off, exposing the underlying capillary beds, and you're going to be bleeding. Not just burst capillaries like we talked about with salmonella, but flat out bleeding into your large intestine. Shigella on its own at the cellular level can invade the cells lining your large intestine. So instead of having to adhere to and try to survive in the lumen of the large intestine as the diarrhea and as the food's moving by, no, this invades the cells, spreads through the cells, gets into the underlying tissues. Thankfully, it has not been shown to go septic. So no bacteremia associated with Shigella. Once the Shigella, the bacterial cell, gets into the mucosa, gets into the cells lining your large intestine, it'll start to excrete different toxins. Makes an enterotoxin that damages the mucosa, causes the cells to start to lose their microvilli, lose the undulations. So it starts to rework the architecture of the cells lining your gastrointestinal tract. And then, as I mentioned in the last slide, the Shiga toxin. It gets in and starts actively killing and damaging cells. So when you look on the left, this is what you would see in an endoscope, through an endoscope, in the large intestine. Okay, this is a macro level. So you see all the capillaries, the little red lines running around. Everything looks nice. Everything looks good. On the right, you see what happens when Shiga toxin. The Shigella bacterial cell itself gets in, starts damaging, killing cells. The Shiga toxin damages and kills more. It's a fecal oral, okay? You are ingesting fecally contaminated water or food. You can also see direct person-to-person contact. Somebody's hygiene's not where it should be. They come touch you, you touch your mouth. There you go. Look at the infectious dose. 10 to 200, okay? Depending upon who you're studying, who you're reading. Few is 10, many is 200 is all you need. Counter that with salmonella we just talked about in the last lecture, which had, hundreds, thousands, millions may be required. Only prevention for Shigella is good hygiene. Good hygiene and being sure that what you're eating and drinking, ingesting, has not been contaminated. Also, not coming into contact with somebody who has said Shigella. Turns out if somebody's sick with Shigella and they have the Shigella dysentery, okay, there's going to be copious amounts of diarrhea, bloody diarrhea everywhere. And if you're their caregiver or you're helping them out, you're going to get exposed to Shigella. Okay, you're going to get exposed to the diarrhea, some form. Cleaning the person, cleaning the patient, cleaning up in their area around them, or just touching them after they've cleaned. Okay, that's the person-to-person transfer. When it comes to Shigella, in a clinical setting, the patient presents, you get confirmation from the ID lab based on, the gram stain, and they've run the tests. You've done, a primary analysis, perfunctory, diagnosis that you think it may be Shigella, and you've started antibiotics just in case. Trimethoprim and sulfamethoxazole are the two that you're going to go with. In the initial short term. You're going to wait in the ID lab is going to send you information back, letting you know, the level of resistance of Shigella to trimethoprim and sulfamethoxazole, and you may go to ciprofloxacin if necessary. The cocktail of trimethoprim sulfamethoxazole is the go-to right now. Cipro is the just in case if you hit a resistant strain.